Thank you very much for the invitation and thanks for attending this lecture. In the last 10 to 15 years, I think a lot of you have encountered a term called deep gluteal syndrome or DGS. And it's a term that have been used quite commonly to replace or interchangeably with the piriformis syndrome. I'm going to just summarize some of the reasons why there's a change and what are the new concepts when we encounter patient with a deep gluteal syndrome. Is there any particular type of treatment we should do? This is my disclosure slides, and most of the pictures are coming from these three books. So let's just pause for a moment. When someone show in a clinic, and what do you think when someone have a pain in the buttock or gluteal region? Now, I'm not talking about your annoying colleague, but I'm talking about a patient who have this with some sort of a symptoms that suggestive of a sciatic nerve irritation. And the first thing you probably would say, can it be just a piriformis syndrome? Well, this is a fairly commonly used diagnosis after you exclude the cause from the spine. And last time I checked, there probably are 25 of those review articles published on piriformis syndrome. It refers to the pain in within the gluteal region associated with sciatic nerve irritation, and you exclude the spine course, and you do some fancy tests like PACE test, BT test, FAIR test, and fiber test. And when you perform those tests and it's positive, and then you think, patient may have a piriformis syndrome. And one of the reasons why people say this because, well, first of all, piriformis is the largest muscle and it's only muscle that transfers through the gluteal notch. And because of the geographic location, the important nerve that go from the pelvis to the lower limb will go above or below, and it's then covered by the real biggest muscle in the body, the one called gluteus maximus, and encodes in a space there. And the second piece of fact I want to just show you is we all know sciatic nerve have known variations with the piriformis muscle, and this article summarized the last 100 years of those report that summarize the variations. And because the sciatic nerve can go above, below, or even in between the piriformis muscle, we believe that when there's some abnormal contraction of the site of the piriformis, it may cause some sciatic nerve irritation. And because of this, we have a term called piriformis syndrome to describe the pain in the buttock with a sciatic nerve irritation. But let's just pause for another moment and think about this. It doesn't sound right. It does not sound right. It does not. So, first of all, it's not uncommon for someone who have a piriformis syndrome to have some investigation. And one of the investigation is MRI of the nerve, the MR neurography. And I would say most of the time when I have those scans done on those patients referred to me, they are normal. They don't have an abnormal variation of the sciatic nerve. The second thing you probably know if you look at the diagram, the sciatic nerve have a close relationship to the piriformis, but also it lie on many short rotator muscles. There are 6 of them altogether. So why do we have to pinpoint one muscle of the 6 and call it a piriformis syndrome? This is the diagram similar to the one I illustrated. The sciatic nerve can usually just exit inferior to the piriformis, but also have an intimate relationship with a number of rotator muscles here. And then there is also a number of nerve around, and is covered by the gluteus maximus muscle and into a very enclosed space that we call deep gluteal space. A lot of things can be wrong in this area. So what is deep gluteal syndrome? It is the presence of pain in the buttock caused by non-discogenic or extrapelvic entrapment of the sciatic nerve. It embraces a much wider spectrum of anatomical structures and etiology of a sciatic nerve involvement. Now, this was termed in 1999, so it's not something too new. if you're interested in this, this is one of the very nice review articles summarized about uh, a lot of things that you should know about DGS. I would like to touch based on a lot of new concepts and what contribute to the new concept or the evolution of the Gluteal syndrome. There are four different aspects. The first aspect is the imaging. Um, there's a different type of new imaging that helps us to understand more about the gluteal space. One is we call dynamic ultrasound. Again, this is a cadaver specimen of the deep gluteal space. You can see the deep to the gluteus maximus. When you remove that muscle, you can see the sciatic nerve lie between the piriformis and a number of the short rotator. If you apply a long axis scan of the sciatic nerve, again, it's a schematic diagram of this, and you can see left-hand side is a cephalad, right-hand side is caudal, the sciatic nerve sagittal scan, and deep to this is the superior and inferior gemini muscle. The tendon here is from the obturator internus, and you can see a larger muscle, which is quadratus femoris. So the sciatic nerve is in a smooth contour. But when you start to interrotate the hip, the sciatic nerve will not assume a smooth contour. And as a matter of fact, you can see here, it looks like it's being buckled. So it's superior inferior gemini, obturator internus, and quadratus femoris. Now, what does it mean? It doesn't mean you will have symptoms right away. But what it does is it decreases the excursion movement of the sciatic nerve. Now, what does it mean? So I will keep on talking about this, but I will get back to the deep meaning of decrease of the excursion movement of the sciatic nerve. The second one is the MRI, the high resolution, or the MR neurography. So here we can see an axial scan. We can see the piriformis muscle here look like a little bit bigger. When you do a coronal scan, you can see the piriformis muscle. Sciatic nerve is around here, but you don't get those details. So there is something called the MRN. You can see much higher detail about sciatic nerve. You see something here, not right. There's something transverse through the sciatic nerve. We don't know what is this, but I can tell you this is a fibrous band that actually is adhered to the sciatic nerve, and it can be the cause for the etiology of the sciatic nerve irritation. And then when you have a better resolution, you can have an even better understanding of the nerve signal praxis with the MRI called MRN. The third is a tractography. It's a special kind of MRI with a diffusion tension scan, and tend to recruit with technique those neural pathway of a similar function together. So that's why we call tractography. It has been used for the brain, but my friend and colleague called Dr. Limos from Brazil, he has already started to work on the possibility of outlining the track of a similar function in the pelvis, and this is called the tractography in the pelvis. And from there, I think you can understand the relationship of the nerve with the tissue around, like the variation of the S2 here as well. All right, the second corner that changed the concept of a DGS is the surgical specialty or surgical technique. One is we call periarticular hip endoscopy. So we are not talking about endoscopy of the hip, like a hip arthroscopy. We are talking about the endoscopy of the extra-articular portion. So if you are interested, there is actually a very good review article dated back to 2012. So what does it mean? Between the gluteus maximus and the short rotator muscle of the hip, the space you can actually insufflate it, and then you can see well inside. And this is one of the setup. You can see the hip there, and put a scope deep to the gluteus muscle. And what does it mean to you? Well, we can see the sciatic nerve in a much better sense, not just in the MRI, which we construct and guess. We can see it directly. So from there, actually, it enhances our knowledge that the sciatic nerve can have some fiber span, and one that we call the compressive fiber span actually tend to choke and decrease the movement of the sciatic nerve. The other is called adhesive. It actually is stuck on the surface and prevent again the excursion movement of the sciatic nerve. I will explain what does it mean in a moment about decrease the excursion movement of the sciatic nerve. You can have a miscellaneous one that actually is circumferential and choke on the sciatic nerve, decrease the circulation and causing entrapment as well. So the advance of this endoscopy technique is not just to confirm to see what we guess from the MRI, say here's a sciatic nerve, there's a fiber span. The sciatic nerve, you can see the fiber span. But most important is the surgeon can actually operate and remove the fiber span. So not just in a diagnostic sense, but also in therapeutic sense. All right, so the next thing about the surgical advance is called pelvic perineology. So it's a group of the gynecologists. They function almost like a neurosurgeon inside the pelvis. One of my colleagues called Zelio Limos, he's a gynecologist from Brazil working with us. He published a kind of a comprehensive experience over the last 10 years about the laparoscopic approach to those extra spinal sciatica and pudendal pain from the intrapelvic nerve. So the orthopedic surgeon worked in the extra-articular space from behind deep to the gluteus maximus. And this group of gynecologists, they work from inside deep to the piriformis and rotator hip muscle. Why is it important? Well, think about this. So there's a lot of entrapment in the sciatic nerve, which contribute from L4-5 and S1, 2, and 3, and can be entrapped inside the pelvis, like within the piriformis muscle. It can be. So I just give you some example. It's very hard to orientate, but basically you are looking inside. This is the caudal. Your scope here is a cephalic and caudal. Here is a S2 nerve, S3 and piriformis muscle here. The S3 have been free from the piriformis muscle. So you can see a piriformis muscle here, and in between there's no piriformis because it was clear because the S3 was entrapped inside the piriformis muscle, So, and this actually is to work from within, and now after you cut free the piriformis muscle, you can see the S3. And this is another one. So they find it's not just the muscle entrap a fiber span. The vessel itself can cause what we call nutcracker syndrome. And here's the one that the S3 again is involved and was looped by this vessel. But by cutting this vessel, you can now see the S3 is now free. So again, there's a new type of understanding about the deep gluteal space. All right, the third corner of the understanding of a deep gluteal syndrome is about the sciatic nerve physiology. One is the dynamic stretching. All right, we know that sciatic nerve is the longest nerve in the body. And when we have some movement like extreme flexion, squatting, we stretch the nerve. And the computer simulating and also in the animal model, we know that 28 millimeter excursion is fairly normal when you do the hip flexion, but it's probably around 3% of the pulling or stretching of the nerve. But when you stretch a nerve by 6%, you can cause some numbness, which can cause a strain-related neuropraxia. And when you stretch a nerve by 12%, that's more than 10%, then you can actually have a complete nerve block without blocking the nerve. So how do you achieve those? So I just want to show you. So when you actually do we call strict raising, and that's the reason why we have that irritation, because you really stretch an irritated nerve and augment those pain from the irritation. So usually by 80 degree, you are achieving close to 6%. But usually we don't keep in this position for a long time. Well, sometimes we do. Well, think about this when you do yoga. We call what's that called? The frog pose. You can do this for some time, and you again stretch your nerve. And you can say, well, I don't do yoga, but in many countries, the bathroom, the toilet is not sitting toilet, it's a squatting toilet, it's a hole on the floor. So if you have some bowel issue like severe diarrhea or constipation, you may squat in the extreme frog pose for some time, and then you can get numbness and you may not be able to get up at all. So this is something that happened. Um, think about this. When you stretch your nerve, and under normal circumstances, you won't actually go to the extreme. But if you have some issue, like you have a scarring of fibrous band in your sciatic nerve, like what I described before. So part of the nerve, sciatic nerve, are not mobile. So when you stretch basically the rest of the mobile sciatic nerve, and then the mobile segment of the sciatic nerve will have strength by more than 3% as you think, because it's a smaller portion of the nerve that is fully mobile, and you can easily go to 6%. So that's the reason why I keep on saying when you have a decreased excursion movement of the nerve is not a good thing. The second is about the understanding of the functional position. Well, what does it mean? For those who actually do running, you know that when you do jogging, running, your hip are rotating all the time. That's why we have 6 rotator muscles. Just keep rotating the hip and rotate all the time. And what does it mean to the sciatic nerve? What it means is, this is the gluteal trochanter, this is ischiofemoral. When you walk and when you run, the sciatic nerve will get closer to the gluteal trochanter, and then in a certain part of the running, and it bounce back towards the ischiofemoral. So the nerve will move medial laterally. I remember some years ago, I was in Hong Kong, and there is a pre-meeting when all the faculty are being given some challenging patients so that we can try to help them to solve. One of them is a sportsman who do a lot of running. So he have no symptoms at rest, but when he start to run, he feel like a sharp stabbing pain down in the sciatic nerve. So everyone tried to examine him, and we investigate and show the previous investigation about the sciatic nerve in the spine. Everything was normal. Well, and including the MRI of the sciatic nerve and the spine. But when we do a dynamic scan, we find that actually when we try to flex his hip and extend the hip, first thing we saw something very strange. He have a known history of tear of the hamstring, which is here, and then he ignored this, and he have a calcified tendonitis, and the calcium is so big and sharp is like a razor blade. So when he walk, the sciatic nerve keep bouncing and hitting the sharp calcium. So that's why he have literally a sharp shooting pain down the sciatic nerve for a reason. And once we know that we diagnose this, the treatment will be easy, because we can just decalcify and break down the calcium, and the patient will feel much better afterward. All right, the last thing I want to show you is how we contribute to the current understanding of DGS is not just the physiology, but also the anatomy. Well, you say, anatomy should be the same. Well, yes, but then we understand better. I'll give you an example. The cause of sciatic nerve. We always say the 6th variation, and then people fixate and obsess with this. But it's not just the variation of the sciatic nerve with respect to the piriformis. I'll give you some example. Here is the piriformis and the other short rotator can have a common insertion site, and in that case, it limits a lot of excursion movement of the piriformis, way more than the variation of the sciatic nerve within the piriformis. And here is another extreme. Even the gluteus muscle attachment are basically have a common origin with all the other rotator muscle of the hip, and in that case, the whole sciatic nerve basically are just quite stuck and very limited in the excursion movement. Okay, the nerve muscle interface. Now, I think this is the anatomy. So the first time people appreciate was due to a Japanese radiology study when they noticed inside the piriformis, is not just a sciatic nerve. The sacral plexus is there. The sacral nerve root is there. And they find quite commonly the S3 and sometimes S2 are inside the muscle. And so that's the reason why we start to do some dissection and find that around 40%, 30 to 40% of the S3 are entrapped inside piriformis. They may not have a symptom, but if someone have a symptoms, someone have a MRI with a swelling, and then we have done a diagnostic block in S3, and they have relief, then we can make a diagnosis. And what does it mean? It means actually the surgeon can go inside with a laparoscopic approach and remove the piriformis muscle, which basically you don't really need it because you have other muscle to help you for rotation, and then free the sciatic nerve. So this is something that we rarely talk about, as we call the nerve muscle interface. So I summarize the 4 different aspects that change the way how we understand the gluteal space, and we can just by understanding this, we know that piriformis syndrome is a way oversimplified version of the description of the type of Peng entity in those patients. So what does it mean to us? I think there's a few implications. One is that pain from the gluteal region have a multiple contributor. There's a different muscles. We can have a piriformis syndrome. We can have the obturator internus syndrome. We can have a ischiofemoral impingement syndrome, in which the quadratus femoris is involved, and we can have a possible hamstring syndrome when the ischiotuberosity attachment from the hamstring, origin from the hamstring is involved. And you can have a multiple neuropathology, so it's not just that a simple picture with a 6 variation of sciatic nerve. It can have a nerve muscle interaction, just like I'll show you that the S3 can be entrapped inside the piriformis muscle. You can have a fibrous band or fibrovascular band involvement, like what I show you in the endoscopy. And we can dynamic compression and traction, which I show you in dynamic ultrasound. And we can have a different nerve involvement because the deep gluteal space, the sciatic nerve is not the only residence. They are superior and inferior gluteal nerve, posterior cutaneous nerve, and then the inferior cranial nerve and pudendal nerve. And finally, the role of surgical management. So in the past, there's not a lot of surgical management options we have. We can talk about injections, we can talk about excision of the piriformis muscle, but now we talk about the fibrous band release, we talk about decalcification, we talk about laparoscopic approach for the detriment of the S3. So there's a much more options, especially surgical options. So approach a patient with the pain in the gluteal region, I think is very similar to a real estate agent. Locations. When someone presents with the pain in the buttock region, there are a few areas that you want to highlight, and like in the piriformis area or in the possible hamstring is a bit lower, and ischiofemoral impingement is deeper. Now I don't put all the 4 different syndrome exactly over inside the GGS because there is a certain presentation of those 4 syndromes that present outside the gluteal space. So I think there's a lot of overlap, but this is good enough. And don't forget one other thing is that we call the refer pain from the lumbosacral junction that we can refer for the buttock, and typically S1 nerve root pain can refer to the buttock area, and they can have some tingling down in the lower limb as well. Okay, let's talk about piriformis syndrome. There's a clinical diagnosis mainly by excluding the spinal and the pelvic cause, and the prevalence is unknown. Around 0.3 to 6% of a patient with low back pain may have piriformis syndrome. Again, we talk about different tests. Primary piriformis syndrome is not as common as a secondary. Primary can compound probably maybe 1/6 of the cause. Secondary, like repeated activity or overuse of the hip area, direct trauma, link discrepancy, or real pocket wallet. I mean, someone who have big wallet and just pressing on the area, or even tumor. The management. I think physical therapy, physical therapy, physical therapy, and this is one of the type of exercise you can do. And what the philosophy is to elongate the performance, because the philosophy of performance is because it have such an intense as muscle activity, and it's causing the pain in the gluteal region. Well, there is some medication people can use non-steroidal, and I find one of the article very interesting is RCT on using mannitol and vitamin, and don't ask me, but I have no idea why it work. And injections, many different way have been described. Injection of a dry needle, acupuncture without touching the piriformis muscle, injecting local anesthetic, or local anesthetic with a steroid, or you inject Botox. And a different modality have been described. You can have a blind technique. You can have a EEG or EMG directed technique. You have a CAT scan, ultrasound, and fluoroscopy. So you have a whole array of this. Now, I'm going to summarize this by what is a known. Well, most of them, they are case series, case cohort. And because of this, all work. All work. Well, this is a very recent article published just last year about the treatment and summarize all the extensive literature on those injections intervention in piriformis. But just remember, what is the name of the game for the case series of the cohort? It means good news. They publish good news. So that's the reason why it seems it always works. Well, I'll give you a little bit more about the known. One is addition of the steroid to the local anesthetic have no added benefit. So people have looked at this in a randomized controlled trial. And they actually study all the way up to 3 months and see there's no improvement in both the pain and also activities. The second is, what about ultrasound versus X-ray? Interestingly, there is I know the group of authors. There's a randomized controlled trial, to compare the two techniques, and they find that the ultrasound have no difference compared with X-ray between the two techniques. Okay, so it's published in a good journal, and we wrote a letter to the editor and say this is ridiculous. Why? Well, when they say there's no difference in all this, okay, I get it. I respect science. But when they show you the picture, I don't know what you make up from this. This is the greater tuberosity, and this is ischiotuberosity. In between, they put a needle there. For those who understand the anatomy, know that between the ischiotuberosity and greater trochanter, this is a classical site, for chordatus femoris. Is no piriformis, my friend, here. They are injecting here and not here. And they show the sciatic nerve, gluteus maximus, and this is a classical site for gluteus maximus. And see what they label here? Piriformis. This is such a wrong article, and I don't know how they can get through the peer review. As a matter of fact, no doubt ultrasound is much better than the X-ray, and there is a study compared with this and find that the X-ray have been validated that only have a 30% success rate compared with ultrasound. So I think it is no doubt that in piriformis syndrome, the target is a muscle, is a soft tissue. X-ray is not an imaging modality to look at the soft tissue. Ultrasound is. So there's no doubt that ultrasound should be the one that prefer over the fluoroscopy. The other known. What about Botox? People have also looked at the role of the Botox. They find that actually compare with just a physical therapy and Botox, there's no doubt that in terms of pain score is much better with the Botox compared with no Botox. I think the Botox certainly have a certain role, especially it is long lasting, around 3 to 6 months. All right, I talk about injection. What about surgical management? This is a very good article again published 2 years ago about surgical management, And I think I'm not going to say yes or no because again, it's also a case series. But I just want to let you know is there's a lot of surgical approach um, available now, and a lot of them are that make sense. So I just want so I in the past I'm very resistant to those surgical approach because they just remove the piriformis. But now we are talking about decompression. They can see the band. They can actually do different things that can help to alleviate the piriformis syndrome. So I just want you to keep an open eye, an open mind on those surgical technique, especially when those are coming from the reputable center. Well, we are anesthesiologists, and when we do injections, I think one of the classical protocol I would suggest is go from the iliac crest there first. From there, you can see three layers of muscle: gluteus maximus, medius, and minimus, and you can see the superior gluteal artery. And you slide down, and then you see a two-layer relationship: the gluteus maximus and piriformis muscle. And then opposite to the tip of the ischium, you can see a sciatic nerve there. And so you need to see the sciatic nerve, you see the gluteus maximus, because you need to define the deep and superficial border of the piriformis before you can inject or insert a needle in the piriformis muscle. And the other thing is about the insertion of the needle. And if you actually insert the needle just besides the ultrasound probe, you may not be able to see the needle because of the steep angle. What I suggest a lot of time, actually, you put the needle just a bit further away from the probe, like 2 centimeter. Then you have a more favorable angle. The angle will be much more favorable so that you can see the needle with the ultrasound probe. It's just a scan to show you one way to augment the visualization of piriformis is by internal external rotation. And by internal external rotation, you can see there's some. Let me just see. I can just go back here. By internal external rotation, you can see the piriformis gliding over there, over the sciatic nerve, and you see the inferior gluteal artery bouncing within that neurovascular bundle. And this is a picture, so you do in-plane from medial to lateral. Well, that's much about the injection technique. What about obturator internus syndrome? So we call obturator internus Gemini muscle. So a lot of literature about this. What we know is, the known is the presentation overlap a lot with piriformis syndrome, but it may augment the symptoms of piriformis. So what does it mean is, if a patient who you think is piriformis symptoms and you do Botox, have some partial relief, you may actually want to add the piriformis to the obturator internus muscle. Or can you inject? Well, just remind you that the obturator internus, if you use the ischium as a border, on the medial side is obturator internus, on the lateral side is more the smaller muscle and maybe even the tendon. So much easier to actually inject into the muscular part. So I just want to show you that in terms of the how we augment the symptoms, is a slide that I showed you before. That the obturator internus and piriformis can have common insertion. So in that case, it can actually augment the gripping of the sciatic nerve, and the other possibility is the overactivity of the Gemini muscle. So when you do the internal rotation, if you have very strong muscle here, you can actually make it bulge out and causing more kinking and more issue with the smooth contour of the sciatic nerve. That's the contribution of the obturator Gemini's muscle. How do you inject? As I say, is on the medial side or ischium. The protocol is very similar to injecting piriformis. You go from iliac crest first, and then go to the sacroiliac fossa so that you can see the piriformis, and then go to ischial spine when you see the ischium become long and straight, and you can see the pudendal artery. But then the next thing is to go to the lesser sciatic notch. That's how you see the obturator internus. So when you are in the lesser sciatic notch here, the ischium become from a long and straight become a very curved, like a red line here. And the obturator internus is on the medial side. And the upper part of this, you don't want to touch because it's an alcohol canal. There's a neurovascular bundle. In case you are interested, you can see the ischiotubus ligament and the coccygeal muscle and levator ani muscle here. So this is a one quick scan. This medial is lateral, is in ischial spine, so iliac crest, and then the piriformis, and then now in ischial spine. Long and straight is a medial, is a lateral. And then later on, when you scan further, the bone contour will suddenly become very curvy. And you can see here it's all black here. So this is the silhouette of the alternating internus muscle. And this is the area you don't want to inject because it's the entrance to the Alcott canal. You inject deep here. So when you put a needle, this actually is inject into the Alcott canal. You want to direct the needle actually much closer to here. All right. And I think it's very long lecture. I will just cover the ischiofemoral impingement and I will be done. So it's first described in 1977, following the total hip replacement. What it described is a narrowing of the space between the ischial tuberosity and the lesser trochanter. And what is at risk here is the muscle called the quadratus femoris. So when the two bony structures are close together, they entrap and impinge on that muscle and can be quite painful. And here is some extreme example. You have very prominent lesser trochanter that make it very closer to the ischial tuberosity, and then in between the quadratus femoris is not having a good time. So again, is a ischial tuberosity, the lesser trochanter here, and this is where the quadratus femoris go through. You can see the difference here is not just is more narrow, the muscle also appear white. Why is white in T2 means water. That means the muscle also have some edema there. So I think that when you diagnose the ischiofemoral impingement, you need to have three component there. One is radiologically, the patient have a decrease in distance in the ischiofemoral space between the lesser trochanter and the ischial tuberosity. The second, you have to demonstrate that is functionally is really narrow in impinge on the quadratus femoris, and I would like to see whether there is some swelling there. And the third is a clinical, whether it's clinically important. So between the lesser trochanter and ischial tuberosity, whether it's impinged, well, by some particular movement. And one of the movement I would love to use is called a Johnson's test. And when I basically have the leg extended, abducted, and external rotate. And you can do it when the patient is standing, or you can do it when the patient is lying down on the side. When the patient have a clinical provocation, when they have a pain on provocation, when the patient have a narrow distance between lesser trochanter and the ischial tuberosity, when I see a swelling of the quadratus femoris, then I would say this is time to say it's true. What is the number to be right? And there is a meta-analysis. And I think I always say that the distance have to be less than 15 before I catch any attention. But when it's less than 10, I think the specificity is more likely to be the case then. Management, physical therapy, as well as a pharmacological. But a lot of time, I will just defunction. So it's a swollen, is a muscle. I just defunction, make it smaller. So how can you make a muscle smaller? So that because the bony space is smaller, the muscle jam inside. But if you make the muscle smaller, then you don't have a problem. How can you make muscle smaller? One of the best tool is repeated, not just once, repeated injection of Botox. But you know that when you repeatedly inject Botox into a muscle, the muscle will substantially smaller with atrophic changes. So that's one of the treatment. So remember, when you do Botox, don't expect one injection is good enough. You need to have a repeated injection. Tell the patient you probably need to 2 or 3 injections to make the muscle very thin. There's some surgery, obviously, because you can treat a secondary cause and resect the lesser trochanter or treat the rotation of the lesser trochanter. I think we have covered quite a lot today, so I'm going to stop here, but I just wanted to give you a take-home message. I would like you to just now understand the concept of deep gluteal syndrome and how it arrives. It basically is a pain in the gluteal region with sciatic pain of extraspinal origin. It really encompasses a different structures, different nerve, different muscles, and different etiology. And the sciatic nerve can be affected by different mechanisms, like muscle-nerve interaction, fiber span, etc. So we needed a dynamic ultrasound scan. We can even use MRN, And the measurement depends on the cause, and I think a multidisciplinary approach with physical therapy and the injection will be a reasonable approach, but in some special circumstances, we need a surgical colleague to be involved. With that, thank you very much.